So LRT stands for low risk TAVR. As you know, TAVR is approved for high risk, intermediate risk, extreme risk, but we don't have approval yet for low risk. So that the purpose of the study was to examine the safety and the efficacy of the TAVR in the low risk population. So this registry was 200 patients. It was conducted prospectively in 11 centers, of which 10 were low-volume centers who never participated in clinical trials in the TAVR field before. And the inclusion criteria was, first of all, to take patients at low risk by the STS score. So they had to have less than 3 in the STS score. They should not have any frailty parameters. So we're talking about real low-risk patients. So we allowed the intervention to pick the device of their choice, as long as it's approved in the US, because it was a US trial. So they used the S3, which is the Edwards, in about 88% of the patients, and the remaining were the self-expanding valve, which is core valve Evolut Pro. So what we present today, the primary endpoint of the study, which was 30 days mortality and 30 days stroke. And we also had in the study design comparator for historical control from the STS database. It did work on the sense that we took the same centers who performed the TAVR and looked at their SAVR cases from the STS database. So we were able to compare by inverse propensity match score the two cohorts for the acute outcome. So let me tell you what was the primary endpoint of the study. This was zero mortality at 30 days and zero stroke at 30 days. These are the main features of the study. At 30 days, we had 1 non-disabling stroke. The pacemaker rate was about 5% in hospital and 6.5 at 30 days. And when we look in comparison to the STS database, their mortality rate at 30 days was 1.7, which exactly matched the STS score, 1.7. Our mortality was 0. It trending towards statistically significant, although that was not the goal of the study. But the conclusion that we can draw from this, that it is safe to expand the labeling from intermediate risk to low risk for TAVR patients. It can be generalized across the board also to less experienced centers. It seems to be safe and comparable and a good alternative to SAVR. Absolutely. I don't think you need more than 200 patients to find out that this is going to work also when you expand it to 800 patients. However, it's going to be interesting to look also on the surgical group, which is going to get all the information and not limited in the pivotal trials. And obviously, the approval probably will have to wait until they will complete their results. But I'm hopeful that it will corroborate the data. It may not be 0, but probably close to 0, if not 0. It's hard to achieve 0.